Welcome back to the 50th Annual AAKP National Patient Meeting. I hope everyone had a nice lunch break, and whether you're enjoying us in person or virtually, I hope everyone took the opportunity to interact with our wonderful exhibitors. My name is Edward Hickey, and I'm proud to serve as president of AAKP. I became involved in AAKP nearly 10 years ago, and throughout my time, I've valued how AAKP stands as an independent, patient-led organization shaping the future of kidney care from the patient's perspective. As a fellow kidney patient and experienced care partner, I've seen firsthand both the challenges and the resilience that define our community. I know what it means to navigate the realities of kidney disease, and I also know the hope that comes when patients, families, clinicians, and innovators come together with a shared purpose. For 5 decades, AAKP has been committed to empowering patients, supporting innovation, and driving policy change in kidney care. This year's National Patient Meeting, 50 proud years of patient education, 50 years of saving lives, 50 years of saving livelihoods, is not only a celebration of our past, but also a look forward to the future we continue to build together. One of great patient care choice, stronger communities, and better outcomes for all impacted by kidney disease. It is my privilege to introduce our next session, The Hidden Burden, Understanding Anemia Across the Disease Spectrum. According to the National Institutes of Health, it's estimated that more than 1 out of every 7 people with kidney disease has anemia. It's a distressing condition that can dramatically impact an individual's health and our quality of life. Based on an independent survey AAKP conducted through our Center for Patient Research and Education, 56% of respondents reported that their anemia affected them both physically and mentally. The effects of anemia are compounded by those individuals who are also on inter-center hemodialysis, with 88% reporting that they felt they were unable to work at their full-time or part-time job after dialysis treatment. But what if there were a new FDA-approved treatment for anemia for adults on hemodialysis? Patients just needed access to it. And that brings me to our next speaker, Dr. Todd Minga, Vice President of Clinical Development and Medical Affairs at Akebia Therapeutics. Dr. Minga is a board certified in internal medicine and nephrology and spent 20 years in private practice caring for patients with CKD before moving into clinical research. Today, his focus is on advancing new treatment options and improving quality of life for patients living with the disease. Please join me in welcoming Dr. Minga as he leads us through this important discussion. Dr. Minga.
Thank you so much. It's a pleasure to be here. Just want to give a big thank you to the AAKP for inviting me here, but I also want to give a big thank you for those that are here, those patients and caregivers that are here. But really, I hear there are quite a few virtually, so we don't see you, but we know you're there. So when I'm speaking to you as well. The hidden burden, I think he summed it up quite nicely. I mean, this is a disease that really entails a significant amount of lack of identification, just like many diseases within the kidney world. Most people that are walking around with anemia don't know they have anemia because they haven't been properly evaluated or had their labs done. So my talk today is really a very practical talk. It's a practical talk for patients and caregivers. I'm hoping to be able to communicate how to better understand what anemia is, really how to diagnose it, and we'll touch a little bit on some of the treatments for anemia of chronic kidney disease. Part of this discussion also allows me to really elevate the level of communication between the provider and the patient. When we see the physician, we have a very finite period of time, typically 15, 20 minutes to interact. There's a multitude of issues to discuss in a very short period of time. I don't know how many times I wish I had more time with my patients to be able to give the background of the disease, really to translate how it impacts their lives into potential treatments. but the reality is we often don't have that time. So I'm hoping to be able to give you a little bit today, some tips and tricks, some pearls about anemia, and really help you understand when you see your provider what some of these numbers and the diagnosis of anemia of chronic kidney disease means. So part of my talk is I'll define anemia. We'll go over some of the ways to diagnose it. We'll go over some of the symptoms and signs of anemia. And it gets mentioned, touch on some of the treatment options that we have. Some you may be aware of and others may not be. And as I promised, a couple of tips and tricks at the end, just to give you some tools when you interact with your provider, some of the good questions to ask, and really better understand where you are in the anemia path, if you will. So, as mentioned, I do work with Akebia Therapeutics. I have the privilege of helping develop drugs for patients with chronic kidney disease. But I also practiced nephrology for 20 years, a very cherished period of my professional life where I encountered people with anemia, encountered people with chronic kidney disease, not on dialysis, and dialysis. So my words today and my slides today are my own, but again, with Akebia's support to help develop, again, new therapies and new ways to treat anemia and other chronic kidney disease problems. So first, this is something to think about. So one of the primary functions of blood is to carry oxygen throughout the body. And if you can imagine, if you don't have adequate oxygen to the organs of the body, they don't function properly. Every organ, think about it, your head, your heart, your lungs, your kidneys, your liver, your skin, every organ in the body requires an adequate amount of oxygen delivery to function properly. When you don't have enough oxygen, each one of those organs has a mechanism to help. But often in disease, they cannot compensate enough, so you end up getting symptoms of anemia. So how do we diagnose anemia? Blood work, just like we hear with our serum creatinine, our GFR. I remember the big push was know your creatinine, know your GFR. And the point of knowing is you can actually take action. When you take action, you can make significant improvements. When you get your labs drawn, part of the normal panel, and this includes your annual physical if you don't have kidney disease, you get your CBC and you get your chemistries, they review them with you, and then they say, you've got a low hemoglobin, you're anemic, so we need to put you on some iron and see how you do. And that's usually the end of the story. With chronic kidney disease, it's a little more complicated. You have chronic kidney disease, now you have anemia, and now we need to put you on a shot, or we need to put you on some other form of therapy to help treat your anemia. But there's never any discussion about the impact or really what the labs mean. So let's take a little bit of a deeper dive into what anemia is. You can see from the center, the test tube. We've all seen this. They draw your blood, and they take this blood, they spin it down rapidly, and the blood separates into layers. The bottom layer, the red layer, is the functional part of the blood. That's the red blood cells. The top part, the yellow part, most of that's water. There's also some other key components of the blood, of course, infection-fighting cells and clotting factors. But the part we're talking about today is the red part at the bottom. When you spin that down, about 40%, just less than half of that tube is going to be red blood cells. If it's less than half, 30%, a third, then you're really reducing the amount of red blood cells or oxygen being carried to every organ of the body, which in turn is the diagnosis of anemia. There are a couple of labs that you'll hear. One is hemoglobin and one is hematocrit. Hematocrit is actually just the percentage of red cells in the column of blood. So if it's 40% or 45%, that's normal. If it's less, that's anemia. Hemoglobin is the oxygen carrying capacity of the blood itself. So you can see at the right-hand side, we have a structure of hemoglobin. These are the red blood cells. Within each red blood cell, hemoglobin is a protein that carries oxygen. So you can imagine if you don't have as much hemoglobin, you're not going to carry as much oxygen. Hemoglobin requires iron to be developed. So without iron, you don't get heme, you don't get hemoglobin, you don't make blood. The normal hemoglobin for an individual, a female would be 12 to 15, for the male 13 to 15. So anything under 12 in an adult female is by definition anemia. Do you feel anemic? Probably not. When do you feel anemic? It really depends on your level and who you are and your tolerance to deliver low oxygen. So if you're a high performance individual and you're climbing mountains and working out every day, it may be a different level of symptoms. If you have chronic disease, chronic lung disease, heart disease, the level of anemia that impacts your life can be different. When you get your labs done to diagnose anemia, there do some other routine labs. Part of that is your iron, as I mentioned, but there's other vitamins like B12 and folate that contribute to normal red blood cell maturity. The red blood cells aren't mature, you don't make blood very well, you have persistent anemia. So the kidneys play a big role in making red blood cells. So the figure on the left is your bone marrow. The bone marrow is where you harbor these cells that eventually will turn into red blood cells that will eventually carry oxygen. The red blood cells are made under the influence of a protein called erythropoietin, or EPO. I think most of you have heard the word EPO because we also use that in a treatment for anemia. As you develop progressive kidney disease, the ability for your kidneys to make erythropoietin decreases. So if you have an early stage, such as stage 3, you may not have a significant amount of decrease of erythropoietin, but as the hemoglobin drops and as your kidney disease progresses, you become less able to generate the amount of erythropoietin to generate the red blood cells through the bone marrow. So less erythropoietin, less red blood cells, more anemia. Part of what's required, as mentioned earlier, to develop good red blood cells within the bone marrow is adequate iron and other vitamins. It was alluded to earlier about the huge prevalence of anemia in chronic kidney disease. So if you have stage 4 kidney disease, which is a GFR of less than 30, approximately 50% of people will have clinical anemia. That's half. Once you get to end-stage kidney disease on dialysis, that number increases to 90%. All based on primarily lack of erythropoietin generation from kidneys that can't produce the protein. So a decreased hemoglobin leads to a decrease in the amount of oxygen. So that's the key. So it's not just low blood, it's low oxygen, right? So think of it as an oxygenation problem. If you climb a mountain, if you go to high altitudes like Denver, you'll notice when you get there, you're out of breath because the amount of oxygen in the air is less than it would be here in Dallas. Part of that delivery of oxygen, we have symptoms. It may be dizziness. Again, it may be shortness of breath, it may be muscle fatigue, it may be brain fog. All the organs are saying, what's going on here? My oxygen level is just not where it needs to be. So your body compensates. So we have ways within our body to compensate for low oxygen. Every organ is doing their best to deliver more oxygen to where it needs to. When you look at the symptoms, think of each organ in the body that's having lack of oxygen blood flow. In this case, the dizziness, the brain's affected, the heart's affected, the lungs affected, the skin, the vessels that deliver oxygen to our skin, our fingertips become less, so we get cold, we get pallor, we look pale. All the symptoms are just, again, that test tube, because there's not enough red percentage in that test tube to deliver the oxygen that's needed to effectively manage the duty that that organ needs to. So if you have a hemoglobin that's normal at 12, and I snap my fingers and give you hemoglobin 11, how will you feel? That's, again, dependent on everyone in this room is going to be affected a little bit different. Some may develop fatigue, just don't feel well, just don't feel like I have the get up and go that I usually do. Others may have a little brain fog, I just can't clear my thoughts. So the symptoms vary and the signs vary. I've seen people with hemoglobins that were extremely low and they look normal, they felt normal. Just like people that show up sometimes in the emergency room with high creatinine or decreased kidney function, just felt a little off. And then because it's such a slow process, the symptoms develop slowly over time. So I want to make that clear that it's not, well, how are you feeling? I feel fine. You may feel fine because it's been such a slow progression of decline that you've acclimated. You know your new normal is just not feeling well. As we have progression of kidney disease, the hemoglobin will drop and typically gets to a threshold where everyone will start feeling the signs and symptoms of having anemia. The problem is there's so many other things going on that we don't know and we can't really separate the issues. Chronic lung disease, again, chronic heart disease, fatigue, musculoskeletal problems, all the things that we would typically attribute to, I just don't have to get up and go, I just don't feel well. Anemia may be a component of that, generally feeling poorly. This is a big one. So when you go to your nephrologist or your caregiver and you, how you doing? I'm doing okay. Just don't have the energy I used to, right? That's a comment. I just don't feel well. It's hard to describe. I just don't feel well. And what do you think's going on? Well, I don't know. It could be my arthritis. It could be my COPD. It could be my coronary disease. And the question is, could it be partly anemia? You check your labs. Hemoglobin could be quite low. It could be in the severe range or the moderate range. And there's a possibility if you treat that component of the spectrum of complaints, you can feel better. But don't ever minimize symptoms to write them off. It's my kidney disease, it's my heart disease. It may be something else. So having a good comprehensive, take a step back, look at your clinical condition, look at your labs, and work on each component of your health to see if you can feel better. So how is it diagnosed? We've been through that. We get a hemoglobin, pretty straightforward. You know, your hemoglobin's 10.5. We're going to watch it a bit, and then we're going to consider therapy when it gets below 10. That's usually the story. That's usually the dialogue. There's never an opportunity to take a deeper dive on anemia when you have so many other things to discuss during these visits. But I will say, as we've often been told, to know your GFR, know your creatinine, I think it's critically important that you know your hemoglobin. It's an addressable problem. It's a problem that can be treated. It's a problem that can be evaluated. And if you don't do a proper evaluation of anemia, then you lose the opportunity to treat it effectively and help, again, make one part of your clinical picture better. Part of that is looking at, I mentioned, checking your iron, B12, folate. But they also may look at other causes of anemia. Maybe your bone marrow is not producing enough blood for another reason. It's important that the diagnosis of chronic kidney disease is based on a thorough initial evaluation. Again, iron, B12, folate, but again, thyroid studies. There are other diseases such as you're losing some blood in your stool and you're anemic. You show up to your nephrologist, you've got a hemoglobin of 10.5, and you say, yeah, I've been to the GI doctor, I have an ulcer, it's been bleeding. That's probably 10.5 because you're losing blood in your gut. That may be one of the causes, but again, it's very, very important that you look at anemia holistically as you would in someone without kidney disease to make sure the clearly reversible causes of anemia have been evaluated and possibly treated. How often is anemia monitored? Typically, that is every 3 months, every 6 months if you have mild kidney disease. When you go in to see the nephrologist or your primary care physician, part of the evaluation is a CBC. So someone's always keeping an eye, and I would just recommend you also be the one that keeps an eye on your hemoglobin. Be aware of where you are, be aware of your symptoms, and be aware of what's being done to help. As you progress in kidney disease, the frequency of evaluation will become more often, especially if you start showing a decline. Then you may have seen every 3 months, in some cases monthly, to make sure, again, that the proper treatments are initiated sooner than waiting for your hemoglobin to drop below a critical level. So what is a significant amount of anemia? As I mentioned earlier, a normal hemoglobin is 12 to 15 in females, 13 to 15 in adult males. Once you get below around 11, hemoglobin 11, that's when we start seeing a level of hemoglobin that we believe, again, some can have symptoms of anemia above 11, but that's when you get to the critical point which some of the symptoms and some of the signs of anemia become more apparent. That's when you get into stage 4 CKD and stage 5 CKD. That's highly prevalent. At stage 2 and 3, where your creatinine is just mildly impacted, your kidneys still have the ability to make enough erythropoietin so you don't end up with significant anemia. So mild anemia is greater than 11. And you see here moderate's between 8 and 11. and severe is less than 8. I would argue that you could put 3 people in front of you. One has a hemoglobin of 7.5, the other is a hemoglobin of 9, and some with hemoglobin 11.2. They may feel exactly the same because of the compensation. What we want to do, again, is to treat patients individually and understand that it can impact people differently no matter what. So if you're saying, I feel fine and I'm at 9, that may be where they are functioning well. Someone at 10.5 to 11 may not function well at all. So this is a very individualized assessment, and again, could impact patients much differently. And the reason we care about the severity is the type of treatment that we would consider is much different for each type. We'll go into that now. So the treatment options, I'm going to say this a third time, is to make sure you're treating what you know you're treating. So anemia of chronic kidney disease should be treated, but you need to make sure that you've also assessed and corrected any other underlying causes of anemia. Again, make sure you're up to date on your colon screening. Make sure you don't have blood in your stool. Make sure your iron and vitamins are adequate. Make sure that you don't have a bone marrow disorder, which most of the time is checked by another lab, to make sure your bone marrow is healthy and capable of producing blood. The other treatments, oral and IV iron. I'll go into this a little bit later, but when you develop kidney disease, as I mentioned, the level of erythropoietin declines. What also declines is your ability to absorb iron. So you're anemic, first thing you think, I need to go home and eat more iron. That's not going to hurt, but it doesn't always help to the degree we'd like it to, because when you have chronic kidney disease, the ability to absorb the iron in the gut decreases. What also becomes impaired is your ability to use the iron that you have already. So you've got all this iron stored up in your liver waiting to be utilized, and your body can't utilize it because of the environment of chronic kidney disease. So oral iron, eating more iron in the diet may help, but it may not be enough. So then there's the other option of intravenous iron, which bypasses those two routes. The third on the list are 2 ways of increasing erythropoietin. We'll go into each one a little bit. One is synthetic form of erythropoietin, that's EPO. Most people that are on dialysis have heard that. That's kind of the standard. There are different forms of EPO. Some last longer, some are more shorter acting. They're different preparations, but the underlying the same mechanism is there, replacing the deficient erythropoietin by given manufactured erythropoietin. Okay, so this is a form of replacement of a deficiency of erythropoietin. Second is a newer class of medications, hypoxia-inducible factor prolyl hydroxylase inhibitors. That tells you the story. It's all right there. These are HIF-PHIs, and what they do is mimic the body being in a low oxygen state. We'll go over that in just a minute. But again, the result is still increasing the amount of erythropoietin that affects the bone marrow, that makes more red blood cells, that corrects anemia. The last, and it should be the least, is a blood transfusion. We had a couple of talks previous today which highlighted the huge advances we've made in transplantation. But one thing that can impact transplantation is having antibodies that help prevent or hurt you from being a potential receiver of a donor kidney. Part of that is the antibodies that get created when you get a blood transfusion. So we always tell all patients who have chronic kidney disease at all costs, think twice before you get a blood transfusion, because it can delay or decrease the opportunity for you to get a transplant. As mentioned, low levels of iron are very common. It's common in the general population, but it is universal in chronic kidney disease. To some degree, iron deficiency is very prevalent. So if you have mild kidney disease and you don't have significant amounts or severe anemia, the first may be to increase your iron intake as mentioned. But as your kidney disease progresses, you may need to get intravenous forms. The oral iron, again, in those stage 3 mild disease, maybe you'll get away with it. IV iron has to be given at an infusion center or another place to start an IV and get. So it is another step, and it would be that would you get a prescription for IV oral iron. The doses are typically given in one dose, a loading dose of IV iron, or it can be given in a series. If you're not on dialysis, it may be given one single dose of IV iron. if you're on dialysis, it may be given periodically during your sessions, a part of your comprehensive anemia treatment. Iron levels are monitored periodically in dialysis. Typically every 3 months or so, you're measuring the iron stores along with the iron, because remember, you can't make, no matter how much erythropoietin you have, you can't make blood without iron. So adequate iron assessment and treatment is number one on the list to treat anemia. Long before you can flog the kidneys, you can flog the body with the EPOs, with the HIF-PHIs, it's not going to work unless you replete the vitamins and minerals required. As with all treatments, they have potential risks, so before getting any therapy, it's always good to discuss the benefits and risk of all your treatments. Second is the synthetic or man-made form of erythropoietin. We talked about how that replaces the deficiency. It's injectable, so if you're not on dialysis, it would be given subcutaneously, typically every 2 weeks or every month, depending on which formulation. When you're on dialysis, it's given part of your dialysis treatment. So that's typically a monthly or twice a month injection through the dialysis apparatus. As I mentioned earlier, the degree of anemia at which we treat depends on many factors. One of those factors is, what is a safe hemoglobin to do two things? One, it prevents symptoms, so it makes you feel better. Two, it prevents some of the cardiovascular or other impacts of anemia. So we want to keep it at a level that you don't have a significant impact. And three, you avoid transfusions. So that magic number we've come up with is between 10 and 11. So our forms of therapy right now aren't treating to normal. There were studies done initially in anemia, especially around the ESAs, the erythropoietin-based therapies, that showed if you target hemoglobins of normal, there is significant cardiovascular risk associated. But if we target a hemoglobin of 10 to 11, we feel comfortable that's the sweet spot, if you will. Helps alleviate some of the symptoms, gives us a buffer for potential transfusion, but also allows us to avoid some of the potential risks of shooting for our higher hemoglobin, which we know would be 12 or 13 in men and women. The hemoglobin is monitored, again, every month or twice a month, depending on your stability of your blood work. As I mentioned, any therapy, the benefits and risks should be discussed with your provider. The next on the list is the HIF-PHIs. These are new on the market, only approved in the U.S. for patients with CKD on dialysis currently. We talked about going to the top of a mountain. Your body senses a low oxygen concentration, so it has all these mechanisms to compensate. Your brain wants more oxygen, your heart, your lungs, your kidneys, every organ wants more oxygen. So there's adaptive mechanisms, and one of those adaptive mechanisms was behind the discovery of the HIF-PHIs. This drug actually simulates or mimics being in a low oxygen state and helps generate more erythropoietin. This is your erythropoietin, not exogenous or outside the body erythropoietin. Most of that erythropoietin is generated by the liver, because we know the kidneys are impacted by that. It's given as a once daily pill, and just like EPO, it's considered when the hemoglobin is less than 10, with a target hemoglobin between 10 and 11. As with EPO and as with iron, it's best to discuss with your provider the risks and benefits of all these therapies. Again, last on the list is blood transfusion. We talked about the understanding where your hemoglobin is helps prevent this from happening. If your hemoglobin's been 11 and the next time it's 10.5 and the next time it's 10, it's time to act. It's time to evaluate for anemia. It's time to get the treatments that are less invasive, such as the iron preparations, the EPO, the HIFs, because the one thing we don't want to do is lead to antibody formation, which reduces the likelihood or lengthens the time to receive a kidney transplant. So blood transfusion may be a life-saving therapy, but it should be reserved as a life-saving therapy. We should be acting and treating patients before they get to the threshold. Typically, that's around 8.5, of you going to the emergency room saying, "Doc, I'm short of breath, I don't feel good." They obtain a lab, your hemoglobin's 8. The next thing you know, there's a bag hanging with blood. And we know the impact of that could be, again, delaying or preventing timely kidney transplant. So this should be self-explanatory, but I'll go into it. So what are the advantages of treating anemia? Just like the symptoms that we see, we restore that oxygen delivery to the organs. We make the organs happy again. We make the head happy, we become a little more clear, a little more clarity in our thoughts. We become less short of breath. We may have more muscle strength. Our kidneys will appreciate it. Our heart will appreciate it. Our vessels will appreciate it. Our body appreciates that normalization or near normalization of treatment. Some may have improvement in their fatigue, depression, even sleep disturbances. All the organs that are affected, appropriate, thoughtful treatment is critical. Reduction in heart problems, improvement in exercise tolerance, and last, there's some evidence that maybe slower progression to end-stage kidney disease. Again, these are all possible with appropriate treatment of anemia. And again, the potential benefits and risks of these therapies should be discussed with your provider. So I'm not sure how long I've got plenty of time, so I'm going to speak either slower or give plenty of time for questions. Tips and tricks. You've heard all these before, but I mentioned the first slide, I think, is empowerment. Empowerment, know your GFR, know your creatinine. I totally believe in that because empowerment and education is critically important. Be part of the process, be part of the evaluation, be part of the treatment, be your advocate. And I would just add another number to your list to be an advocate for, and that's your hemoglobin. Know your hemoglobin, know the potential treatments, know when the appropriate treatment with discussion with your provider. So here's the voodoo. It's getting close to Halloween, so I threw that in there. If you don't monitor your blood, you really don't know where you are. So when you go in and you get your blood work done, and you miss a month, you miss 2 months, well, I was busy, I was traveling, I didn't get a chance to go get my labs done. And you look at your provider and you say, I just didn't get it done. And they look at you, well, I have no idea where your hemoglobin is. I have no idea where your creatinine is. So the point is, get your routine labs done. This is the critical number, these are critical numbers to help you know where you are in the spectrum of disease. Know your hemoglobin level, know your hemoglobin level. Know what normal is, know your trends, and again, know what the threshold is for treatments and for treatment options other than your standard oral iron. And communicate your symptoms. I think we get into an environment where we don't feel well, and all we want to do is minimize that. I don't know how many times I heard, how you feeling? I'm feeling fine. And the person next to them rolls their eyes and says, you don't feel fine. Because they want to be nice. They want to communicate, it's a pleasant day, it's sunny out, I feel fine, doc. When really they've found it difficult to walk the steps, they found it difficult to go on excursions with their family. They just don't feel well, and it happens slowly. So communicate symptoms. Now, there may be nothing that can be done. It may be part of the disease, right? But if there are correctable issues, we should be evaluating them and addressing them. And anemia, again, is part of that spectrum of disease where correction of anemia could impact your quality of life. And when you say, I feel fine, maybe that is the truth. You can't make blood without iron. So I think it's critically important that we address the iron deficiency, especially as we progress. We're in an unfortunate environment where a lot of these therapies require you to go to another doctor or to an infusion center to get IV iron. But it is such a crucial part of making red blood cells that it's imperative that if the order is, we hear this quite often, we're going to try oral iron and see if it works. And 3 months later, it didn't work. So the nephrologist says, we're going to set you up to go get IV iron. And you roll your eyes, give me 3 more months of oral iron, I'll eat my spinach, I'll do whatever I need to do, doc. I do not want to go to another doctor to get IV iron. It's critically important to replace that iron because anemia is not going to get better until you do. I think I've said this at least 3 times, avoid a transfusion if possible. Ask the questions. Your nephrologist, your kidney care team understands this, others may not. So when you're in the environment where they don't understand kidney disease and some of the ramifications and tolerances, it's okay to ask, to call my provider to say, do I really need a transfusion? The answer may be yes at the time. It may be an emergent need, but it's always worth the pause to say, do I need to get blood transfusion? Doc, you know I have chronic kidney disease. I'm hoping to be on the transplant list. Could you please reach out to the kidney care team to evaluate to see if I need this transfusion? I think that's critical. And understand the benefits and risk of all treatments. All these have benefits, but all these have risks. So it's always, please be informed, understand the benefit, but also understand the risk of all treatments. And as always, keep the appointments, take your medications properly, and be an advocate, be empowered to take care of yourself. My last slide is, I can be changed by what happens to me, but I refuse to be reduced by it. And I'll stop there for questions.
Thank you, Doctor.
Sit or stand?
Appreciate it. Stand over here. It'd be
Okay,
great.
I'll
You
stand.
can sit. I think that mic's on too. So, thanks for walking us through this condition. It's just remarkable, and just talk about the innovations that can elevate our lives. We really appreciate it. We have some time left for some questions from the audience. So, if you have a question for Dr. Minga, someone from AAKP will bring a microphone over to you, and we'll get you in front of them. I have one. We'll get started. For new treatments and innovations are of tremendous interest to vulnerable kidney patients and their families. From your perspective, how important is it for patients to engage with their kidney care professionals and actively discuss all available care choices and which treatment may work best for their needs? I know you alluded to it during your talk.
I did allude to it. I think that part of that discussion is being knowledgeable. Again, you should have the option to understand what's on the table. Just like when we go to a restaurant, we have a menu of choices. We've got the small bites, we've got the soups and salads, we've got options, and we get to pick which one we want. In healthcare, I think if there are different options, as patients, we should be able to have a say in options. Again, it's weighing risk and benefit. I use the analogy of dialysis. If we get to the point where we need dialysis, we are given an option, right? We're given an option. We're given the risks, we're given the benefits of hemodialysis versus peritoneal dialysis, whether we want to do home hemo. That's a huge advancement over the last 10, 20 years. Didn't used to be that way. You sat there, the doctor told you what you were going to do, and you went home and you did it. We've gotten to a different place now. We've gotten to a place now where patients are informed, and I think anemia is the same. Let me know what the options are. And as a patient, I should be able to evaluate each option. Again, looking at the potential benefits and risk, and I should be, as a patient, able to choose the option with the provider's help that is best for me. Not being told this because it's available and this is not available, to be told this is what I always treat with. Again, I think it's empowering patients. The more you understand, the more likely you're going to be offered options. So
Thank you for talking about this, and hopefully I'm not putting you on the spot on this, because talking about anemia is extremely important. But what about having high hemoglobin? When you take an Epigen and stuff like that, what are some of the side effects of high hemoglobin, and what can we do about lowering it back down?
Yeah, I appreciate that. I mentioned that a little bit. There's a subset of people. I think the number was 90% that I said of patients with end-stage kidney disease that have anemia. There's also 10% that don't have anemia. Polycystic kidney disease is one disease where you tend to retain the amount of erythropoietic effect, and you typically don't have anemia like other forms of chronic kidney disease. I'm hoping I'm answering your question appropriately, is that when we're treating disease, again, we have to be careful, just like with our blood pressure medications. If you have a blood pressure of 150 over 100 and you get a blood pressure down to 130 over 80, that's fine. But you can have too much therapy, right? You can get down to 90 over 60 and have complications. That requires thoughtful, careful monitoring. Same with hemoglobin. Patient presents anemic, you provide enough iron, you start them on a therapy, the blood pressure, hemoglobin goes up nicely, and then there could be a potential to overshoot, to be too corrected or too normal. And there is, as I mentioned earlier, there is a potential cardiovascular risk of being too aggressive. So once these assessments are made that your hemoglobin is going up too fast, the goal is close monitoring and reducing the therapy. So what we want to do is, just like we all do, our hemoglobin stays like this. It's remarkable. Just like our creatinine, just like everything else, our body has an amazing way of compensating, so we stay stable. When you're treating disease, we see a little bit of this, right? It goes down, I treat. The goal is to mimic the endogenous activity of the body and to have a hemoglobin that stays nice and steady. So the best thing you can do is to evaluate the treatment options and to have close follow-up and monitoring and dose adjustments of those hemoglobins. You may need to have the therapy held. That's typically the way to do it, reduction of the dose of medication. But there's ways, and I think the monitoring and reacting to trends of hemoglobin helps prevent some of that. We want therapies that are gentle. We want therapies that really resemble as much of the way our bodies typically work, is to normalize and not to have ups and downs throughout therapy. Easier said than done. Again, 20 years in practice, that was always the goal, to have someone 10.5, 10.5, 10.5. That's never reality, but that's our goal, right, is to close monitoring, close assessment of the response of the drug, making the adjustments when you need to. Did that answer your question?
Yeah, could you go over the side effects of high hemoglobin, though?
Yeah, so there were a couple of very large studies done. Treat, Choir, there's numerous that were done, again, early on when we started having options for treatment, especially with ESAs. We didn't know any better, so we had to target hemoglobins, which you would think would be normal. Why not? If your blood pressure's high, you want to normalize it. If your hemoglobin's low, you want to normalize it. What we found is there was a risk of cardiac or cardiovascular events, stroke, heart failure, heart attacks, when you're targeting hemoglobins that are normal. So the goal, based on those studies, if you see it in all the labels, is to not target hemoglobins that are normal. You target hemoglobins that are a gram or two below normal, again, the 10 to 11. Interestingly, patients who don't require. So what about the patients with end-stage kidney disease that don't have anemia? A subset of polycystic kidney disease patients who have a hemoglobin of 14. Do they have an increased risk of cardiovascular because their hemoglobin's higher? No, it's just driving hemoglobin to an excessive amount, and again, defining that as near normal, does lead to increased risk of cardiovascular events based on those studies. And that's why the label, if you look at any of the ESAs, if you look at HIF-PHIs, you don't target normal, you target just below normal to help, again, balance that benefit and risk. So that's why it's important, I said, to talk about some of the risks and know your hemoglobin. You're part of it. That's the important thing.
Excellent.
Okay, good. All right, thanks so much. Appreciate it.
Thank you very much, Dr. Minga. Appreciate it. That's all the time we have for this session.